Patient has cervical disc herniation, osteophytes, degenerative disc disease with annular tears, of course, at the back of the disc at C3-4, C5-6, and C6-7. The patient's having neck pain for a long time and pain going into his left arm and weakness, subjective weakness, and sensory loss on the left side. He's also having headaches from his neck. We call those cervicogenic. Cervical because it's a cervical spine. Genesis is to create or originate from. So cervicogenic headaches are headaches that come from the spine. Now, we never do more than 4 discs at a time, and this patient doesn't have 4 but 3. So we're doing a C3-4 disc, and then we're doing a 5-6-6-7. Now, this patient traveled from California. He's an engineer, and he was offered fusion surgeries in California. He did not want an anterior cervical discectomy and fusion. So Diego, you want to run a little bit of the ACDF video so the crowds can see the difference. The ACDF is an anterior cervical discectomy and fusion. There's a big incision made. We have to move everything over. It creates a massive amount of scar tissue from the surgery, and there's going to be a metal plate in there and fusion of bones. He did not want fusion. So we're avoiding that, and we're going to do 2 tiny little incisions. We're going to repair all 3 discs with 2 little incisions. All right. This is the most perfect positioning I could have asked for. So thank you guys. Great job, Luis, doctor. Shot. All right. So we're a little bit lower than we need to be. We need to be at C3-4. Now C3-4 is tough to get to because of the jaw and the salivary glands. Shot. All right, that looks pretty good. Guys, I need you guys not to move anything. Can you give me some inline traction? The head is moving a little bit because I'm up high in the cervical spine. So the first step is I'm going to gain access to C3-4, leave the needle in there as a marker, and then I'm going to go for 5, 6, and 6, 7. I'll come back to 3, 4 later. All right. So we're going to use our fluoro shot. 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 AP quick. Stay where you are, doctor. I'm almost done. Give me a quick AP now. Please, I need you to be on target. All right, so the neck has moved way too much, and you're way rotated. This should be there. No, other way. Shot. All right, let's go back to a lateral now. So this whole time I've got my fingers in here. Shot. And I can tell you it's from a physical standpoint, for me it's very painful to hold your fingers here. Shot. 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 All right, let's give me a Coker, give me an AP. So we all agree that's 3, 4. All right, now let's take our time, and that looks really good. But let's come on, give me a good AP view. Let's get the head straightened out. Doctor, can you straighten the head and neck so we can get a nice AP view? Now, while we're doing this, we're getting the spine and head lined up. We're getting the fluoro lined up so we can get a good AP view. Is that better? Yeah, I think that's better. It looks perfect, actually. You can see the tip of the needle is right in the center of the spine. So we're done with that. Let's go back to a lateral. All right. So you're watching the most state-of-the-art advanced spine surgery in the world for the most common condition that affects the spine. And let me break it down for you for a moment. The spine is basically bones stacked on top of each other with joints between the bones to allow flexibility. The most flexible part of your spine is your neck, your lower back, and the thoracic spine in between is stabilized by the rib cage, so there's not a lot of movement of the thoracic spine, but there's still bones and discs in there. The most common cause of pain in the spine is going to be a herniated disc. It has many names: herniated disc, bulging disc, extruded disc, protruded disc, ruptured disc. I mean, there's even more, slip disc. So the names you give it are many, but it's the same condition. And then once the herniation occurs and it's fresh, you get a tear in the back of the disc in the annulus. You get jelly pushing through the tear. That's the herniation or bulge. And a bulge is just a small herniation. Over time, inflammation inside the disc where the tear is and the herniation is causes the disc to degenerate. So Deuk Spine Institute is the first place in the world to discover the cause of neck and back pain from a herniated disc is actually a tear in the back of the disc called the annular tear, and it's inflammation in the tear. Diego, are you going to show them the video of the cervical spine of what causes chronic neck pain? Do you mind doing that?
Yes, I'm playing it right now.
So they can see the tear. Are they able to hear me over the video or not?
Traumatic
Yeah,
injury on the disc can cause annular tears to
Let me know when you want
form.
me to talk.
Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a
See, he's like this. We can't have that. Let me know when.
You're back.
All right, so I hope you understood the animation we created to explain the cause of pain in the neck and headaches. But it's that tear in the back of the disc that gets jelly or nuclear material stuck in it, causes inflammation, and that inflammation then causes headaches in most patients, neck pain, and then it can irritate the nerve roots and cause arm symptoms, okay? So it's the inflammation in the back of the disc, and again, that was discovered here at Deuk Spine Institute, and that's why we're able to cure neck and back pain, because we go in and use a laser to clean up that tear, get rid of the herniated material, and allow the tear to heal normally without pain. Now, we do all this without fusion. So I've already accessed C3-4 disc. You can see on the lateral x-ray, I have the needle in the center of the disc. I'm going to do a discogram. But before I do that, I want to access the 5-6 and 6-7. So we're doing 3-4, 5-6, and 6-7. We're skipping 4-5. Everybody in agreement? All right. So I need you to hold these tubes over because you can see the tube there on the view. Now you have an esophagus tube in, right?
Yes.
Okay, good. So we got our endotracheal tube. This patient is intubated under general anesthesia, completely asleep, laying on his back. And we also have the endotracheal tube in the trachea. We have an esophageal tube behind that in the esophagus. So I can actually feel those tubes with my fingers, and that way I can displace them to the side with my fingertips as I touch the spine. All right, so I'm going to go for the 5-6 disc. Let's see, or should I go for 6-7? I'm thinking I'm going to go for 6-7. That would be better, because if I get into the 6-7, which is harder to see, then I can move up to the 5-6 afterwards. So I think that's the right call. So I'm leaving one of my needles in 3-4 because I've already marked it perfectly. And I'm going to go for the 6-7 next. All right, so what's going on down there at 6-7? We're going to need a little bit of shoulder pull. You're going to have to help me, okay? So you're going to take the shoulder and the ball, and you're going to feel it with your fingertips. You feel that?
Yes, sir.
And you're going to just gently pull it south.
Okay.
Not much, just a little bit. We pull his head in inline traction. And let's just get a quick shot and see where we are. Shot. All right, so 2, 3, 4, 5, 6, 7. There's 6, 7. All right, so I'm going to try to get my needle in 6, 7. Once I have my needle placed, then I know we have a safe path to the disc. I want to make sure I'm not moving 3-4. Shot. All right, so that's even lower than I need to be, which is good. And shot. All right, I really can't see. Your fingers are in the way, actually. Shot. All right, so 2, 3, 4, 5, 6, 7. I'm a little bit higher than I need to be, which is actually pretty good. I could just pull south a little. Shot. And that looks pretty good there. Let's go with AP now. Quickly. Shot. I need a quick AP. All right, I'm off to the side a little bit. Go back to a lateral view. Shot. Shot. Let's get a, hold on, let's get an AP. Again, you got to get me a good AP. I think I'm off to the side. Yeah, I am. Shot. That's better. Lateral quickly. I need you to pull just slightly out down here on the shoulder. That's it right there?
Yes, sir.
Shot. All right. It's getting worse. Shot. All right. I can't. You got to get over here, Luis. He's not ready for this. All right, so what I'm trying to do, I need you to give me inline traction with the head not rotated. If you rotate the head, it rotates the spine. It makes it harder for me to see. The head has to be straight up and down. All right, now who's pulling on the arms? You are? Not too hard. And let's just see what we've got with Luis's giving a shoulder pull and you giving a shoulder pull. Come on. Shot. All right, so 2, 3, 4, 5, 6, 7. That's really good. If we could just keep that view. You should probably come a little more south, Jordan, just a little bit, like a half an inch at most. All right. All right, I need to see that 6, 7, and you need to be able to give me an AP view quickly. Now, again, I don't know how he airplaned his body. I just don't understand how that happened. Somebody want to tell me? Did you check to make, I mean, you can see.
Position? Yeah.
Huh?
After the position, you said, or during the position? You mean like a...
I'm asking you a question.
Yeah.
You're in charge of positioning.
Yes, sir.
Do you see the body is twisted?
I see it right now.
All right, so how can we let that happen? It should never happen. It's supposed to be straight up and down. If you twist the body, you twist the spine. It makes my job a lot harder, which is already hard enough to do this.
Yes, sir.
All right. All right, are we good? We're gonna give this a try. Give me a little bit of irrigation here. Helps my fingers slide on the skin a little bit better. Shot, let's just make sure 3-4 is not moving significantly. All right, good. Let's see where we are here. Shot, okay. That's better. And shot again. It's a little too high. Let's see, hold on. Shot. Shot. I need a little more there. I can almost see the gap, Luis.
Yes, sir.
Shot. Now, give me an AP. I think we're off to the side. No. You cannot release. Shot. Yeah, we're off to the side. Back to a lateral.
Ling, are you pulling, right? Yeah. All right.
Shot. 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 Coker. Oh, good. Relax. I think we're there. That was tough. Whew. My fingers feel like they're going to fall off. All right. Give me an AP. That's good. All right. And the lateral. Let's just look one more time. Okay, so you're watching live surgery. We don't edit our surgeries. You get to see everything. There's no other surgeon in the world that will show you live surgery of the spine.
Wait,
We've been doing it now for several years. 2, 3, 4, 5, 6, 7. 2, 3, 4, 5, 6, 7. Everyone agree?
Agree, sir.
All right, relax. We're in the right disc. We're in the right position. All right, so let's just take a breather for a moment. And what we're doing, for those of you who don't know, is I have my anesthesiologist stabilizing the head, holding it neutral, and giving a little bit of inline traction where we pull slightly and extend. And then I have Luis pulling the shoulders down, and so we can actually see C6-7, because the C6-7 disc is very hard to see. It's really at the bottom of the cervical spine. The shoulders come into play and they block the x-rays from passing through to give us a good visualization. But I'm happy with that view. All right, so next, like I said, we're going to do our discograms. We'll start with C3-4, which is the top disc we'll be fixing today. And then we're just going to let it sit until we get to it at the end. That will be the last disc we do. Shot. All right, there's our discogram. You can actually see the dye leaking out through the tear in the back. It's outlining the herniation at C3-4 at the back of the disc. All right, but that will give a shot. That will give us a little bit of the blue dye that we love so much to stain the nuclear material that's degenerated with blue, because it's acidic, and degenerated nuclear material is acidic. And so, of course, acidic disc material is degenerated disc material. Shot. Yeah, and I want to make sure this is in far enough. Shot. That's good. All right, that's perfect. We'll leave that alone for now, and we're going to focus on C6-7 next. All right, so to see the discogram, we'll probably have to pull the shoulders and head one more time, and then I'll have to do it one more time just to get my instruments advanced. So nice and gentle. And so it's more of a squeezing in and down, but not too much. Are you getting the head? Shot? Let's see where we are. Is that where we are there? If you can just give me a little head pull. All right. Shot? Good. All right, we got the herniation is stained there. You can see it. All right, good. Relax, everyone. Relax for a moment. So we've done the discogram, and disco is for the disc, the spinal disc. Gram is basically an imaging technique where we're using an x-ray, which is this fluoro machine here, and we're entering a dye into the disc and looking at where it's leaking out. And you can see it's leaking out in the front and back. The front leak out I'm not concerned about. It's not causing any problems for him. It's the one in the back where the tear is. That's where the pain comes from. So now I'm going to go ahead and place my guide wire, and again, let's just get a shot without pulling the shoulder, see where we are. Shot. Yeah, the shoulder pull is not really helping much. Well, hold on. So let's think about this for a moment. 3-4 looks good. It hasn't moved. So we got 2, 3, 4, 5, 6, 7. C6-7. We're still at C6-7, and I'm going to place the guide wire again, and then we're going to remove the needle. Give me a slight pull, Luis, on the shoulder, and give me some inline traction, please, doctor. Well, hold on. Don't pull yet till she gets the head. Otherwise, you're just pulling everything south. You got to let her pull the head north a little bit.
You ready? Okay.
Yeah, just a little bit. Shot. Yeah, that's perfect. That's all we need. Let me just see if I can see the guide wire come out. Shot. It looks like the guide wire's there. Difficult to say for sure. Shot. So I'm going to start pulling the needle back, shot, and just see if the guide wire stays. There it is. It looks like it's staying, shot. Yeah, so needle's out, guide wire's in. Now the guide wire is going to allow me to navigate to the disc with my dilator. And the dilator is going to open up things just enough for me to do the surgery. Okay, everything looks good. We've lost like 2 drops of blood. That's less than 1/10% of a milliliter. It's nothing. You can see we're going to inject a little bit of local. This is just some lidocaine with epinephrine, just to numb up the skin and to arrest any capillary bleeding that might occur. Most of it's leaking out through the needle hole. You want to be careful not to go deep, and you don't want to inject this into a vein, obviously, but you want it sub-Q. I injected about 1 ml sub-Q. The rest of it's leaked out. All right, so we're going to get started at the bottom 2 discs. We'll fix those first with the laser surgery that we do, the Deuk laser disc repair, and then we're going to work on the next one at 3-4. It's a 4mm incision. 4 millimeters is tiny, for those of you who don't know. The whole surgery to fix 3 discs will be 2 little 4mm incisions. Okay? 4 millimeters is almost nothing. It's literally like a razor scratch on your neck if you're shaving. There it is. See it? You all see that, Diego?
Yep.
Now I'm going to bring the dilator. What does a dilator do? It doesn't cut. It spreads. And believe it or not, you can spread tissues inside the body. Not the skin, but everything under the skin can be spread. And by spreading things, you don't damage them. You just spread them apart and they come back together. You can't spread bone, but you can't spread skin. You really shouldn't spread nerves, but sometimes we do. But the main point is everything under the skin here can be spread apart. Okay? Who's moving his head? Are you moving his head?
I'm just testing his switches.
Yeah, I don't want you to do anything while I'm doing this, okay? Shot. Let's make sure everything's going well, which it is, and we're on our way down with our dilator, and I give it a little twist as I go so I can, it doesn't grab tissue on the side, and pull. Some of the like what you're seeing right now, which is called the access or exposure. But most spine surgeons, they're not taught any of this in training. They're taught to put in metal, do fusions, and artificial discs. They're not taught to do endoscopic spine surgery. Endoscopic spine surgery is relatively new. Now, it's been going on in Europe for probably, and Asia now for probably a good 10 years, 15 years. True endoscopic surgery, but not many surgeons know how to do it. And the reason is that there's a paucity of training. There's nowhere to go to get trained, and there's equipment that's very expensive to buy, and it's not available in most hospitals. Let's get an AP. So it's a training issue, it's an equipment issue, and to be honest with you, it's a hard surgery to do. So there's what's called the steep learning curve. It's not easy. Shot. All right, good. We're in the middle, just slightly to the patient's right side of midline. And what I'm aiming for, there's 2 muscles that run on the front of the spine up and down called the longus colli muscles, and I want to avoid them. I want to be between them, and that's as long as you're between the longus colli, and there's probably about 5 millimeters or half a centimeter of space between them. You're fine. All right. So can we make that better? I think you got to wag a little bit so we can see down the disc. Let's try to get our picture. So I'm taking time right now, stopping the surgery and waiting for my technician to line up the fluoro better. You see those 2 dots in the back of C6? Let's try to line those up. Those are kind of the pedicles. If we can get them a little bit better lined up, I mean, that's definitely an improvement. but I think we could do a slight bit better. So because I have to use the X-ray picture to navigate to where I want to go, I think that's worse, if you ask me. Whatever we did, we made it worse. You agree? Because I have to use the X-ray to navigate, Sean, I think that's, no, it's not much worse, believe it or not. It's actually, I could see the disk space now, whereas before I couldn't. So I'm just going to have to be happy with this, okay? I'm going to have to be happy with this. So because I'm using the X-ray to navigate, I want to make sure it's showing me reliable information. So I need to make sure I calibrate it, so to speak, with the spine and make sure it's lined up properly. Okay, I can feel myself passing through the anterior disc, and we're heading towards the back. And I can take this guide wire out now because I'm inside the disc. So I've safely made it from point A to point B. Point A being the skin to point B being the back of the disc. I'm almost at the back of the disc. And I'm just gently twisting this in. I can feel it with my fingertips, okay? Now I've gone as far as I can with my fingertips. If I push harder, I may suddenly give and go into the spinal cord. It could paralyze a patient. We don't want that. So I'm going to use a hammer. And I know for most of you watching, you're thinking, well, if it's delicate, why would you use a hammer? You know? And the answer is, with a hammer, you can actually control how much energy you deliver. And I can do that, and I can feel the advancement of this dilator. So it's actually safer to use the hammer, much safer. Okay, I'm not hammering a nail into a roof. I am basically just advancing the dilator. Now for those of you may have noticed that the angle of the dilator has shifted from this way to that way, because it's sliding along the disc now, between the end plates of basically C6 and C7, right? 2, 3, 4, 5, 6, 7. So when I started, put your hands up. I'll use Luis's vertebrae. There's the disc space. So I started at kind of an angle like this, and it hit the top of the end plate, and then I brought it down as I advanced it, so it's sliding now parallel to the end plates. All right? So I feel really good. We're at the back of the disc. I can see it on the X-ray. We're at the proper level, C6-7, which is the bottom disc we're going to do. And now we're going to do the entire surgery through this tiny metal tube, folks. This is a Deuk laser disc repair. We are repairing 2 herniated discs, 5, 6, 6, 7, and then we're going to come up here and repair 3-4. Okay? So I've kept my eye on the 3-4 needle, make sure it hasn't moved in or out, and it's in good position. So right now I'm going to focus on fixing C6-7 disc. For those of you that have a herniated disc at C6-7, you can avoid fusion surgery, artificial disc surgery. This patient's not a candidate for artificial disc anyway, because he's got too much degeneration of the disc at C5-6, C6-7, and C3-4. I don't know any surgeon that would do artificial disc. It's not indicated. There's contraindications because of the structure of the disc being so degenerated. But anyway, fusion would be a good option for him as a second surgery if he was not able to do the laser surgery that we're doing right now. But don't expect your spine surgeon or neurosurgeon to tell you about the surgery, because they don't know about it and they don't know how to do it. This is more advanced than anything they've been trained to do. And he went to UC San Francisco, which is one of the top neurosurgery programs in the country for training. They don't know how to do the surgery. They could just offer him fusion. He didn't want to settle for fusion. He's an engineer. He's a smart guy. He knew there were better options out there. He searched and he found us. Why do we broadcast? Because we want the world to see the truth. You don't have to do fusion surgery. All right, so I'm advancing the tube through the disc. You can see that the tip of the dilator is not moving. I'm checking my C3-4 needle as well, which is slightly deviated from the tissues being pulled south by this process right now, but it's still anchored in a good spot in the middle of the disc. All right, I'm just about to the back of the disc here with my tube. Yep, almost there, and I want to advance my dilator just a few millimeters so I can get my tube a little further in. Shot. Any questions from our audience? No?
Yes, we have one person saying that they started corresponding with this patient shortly after her own cervical DLDR. She's very thankful she's getting her disc repaired today.
Wow, thank you. That's awesome. It's great to hear. That's how we're going to change the world, folks, is by spreading the word and, you know, sharing experiences. And that's what we're doing today, sharing experiences, spreading the word. So you can see the tube is now passed through the disc. And people say, well, aren't you damaging the disc when you're passing through it? The answer is no. The disc is already damaged. We're not damaging it anymore. We're actually spread the jelly in the middle, and we have spread the jelly to the side, and then when we take the tube out later, the jelly will come back. So we're not doing any damage to the disc whatsoever. The only thing we've damaged in this surgery is the skin. We made a 4 millimeter incision, which is dramatically smaller than a fusion incision. Now, what's wrong with fusion incisions? Everything. When you get a fusion incision, it's not the scar on your skin that's the problem. People say, well, I don't care about the scar on my skin. I don't mind people seeing my scar. Great. It's not the scar on the skin that's the problem. It's the scar underneath the skin that you can't see, that's scarring your swallowing tube and your trachea and your carotid artery and nerves. It's scarring all those tissues together and scarring your swallowing tube to the metal plate right behind it. That's the scarring that's the problem. It's not the aesthetic scar that we worry about. It's the scar tissue that forms on the spine between the spine and the metal plate. And that's what causes trouble swallowing and voice change. I had a patient that is a singer, a musician, and he was considering a fusion. And you know that one of the most common lawsuits with fusion surgery on the neck is that people's voice changes, and they're professional singers. So a lot of professional singers don't realize if you do an artificial disc surgery or a fusion on your neck, you're going to have a change in your voice that's going to be permanent. Now, if it was my singing voice, it'd probably be an improvement because my singing voice is terrible. But for a professional singer or anyone that uses their voice professionally, you don't want fusion because that's going to ruin your voice. Guarantee it. Okie dokie. So now, well, let's show the audience the rig real quick before I go in. Can we show everybody? I know the patient's going to want to see it.
Yeah, they're seeing it.
All right, pretty cool, huh? So this is the endoscope itself, this thing. And it's got a light source right here, which feeds light into the fiber optic system, and that brings the light down here. You got your laser fiber here, which is 0.5 millimeter, 0.5 millimeter wide. You've got irrigation, which we have cold saline irrigation, and we got our high definition camera. All right, so here we go. This is called a single port or uniport. This is what, I hate to say it in this way, but real endoscopic spine surgeons do single port endoscopic surgery. There's a big push now for biportal because single port is too hard for most surgeons to do. They don't know how to do it. It's too complicated. So they're doing biportal, which I think is a cop-out. And you have to have 2 incisions, and it's not as good, you know. And I'm not talking about for the neck. I'm talking about for the lower back. Nobody else does the neck except the Koreans and maybe a couple of Chinese. I think there may be one German surgeon that does cervical disc surgery through the neck. But they do fusion technique, and they don't do the Deuk laser disc repair. What makes the Deuk laser disc repair unique and different than any other spine surgery is the annular debridement. It's the debridement of the annulus fibrosus. Should we move the water irrigation or just leave it? Let's try and see what happens. All right, so we're bringing this endoscope down. Here we are at the back of the disc where the herniation is. And you can see that you're at 20, correct? Yes, sir. Yeah, you can see the pink material. I just kind of zapped it. It's faintly pink. My eye is good at seeing it. Now this is all herniated disc material. We have a little bit of end plate cartilage right here. All right, got some stuff stuck on the laser. This is a herniation right here, this blue thing. Okay, we're going to get it out in just a minute. Look at it, it wants to come out the tube. So I got to free it up enough that it comes out. Now that's what I'm doing. I'm detaching the herniation. Why would the herniation be attached? Let's see who's paying attention. They get scarred. They get scarred in. The herniations happen and they stick to the annular tear and they get scarred in there from inflammation. I don't think I got it, but try.
Yeah, you can say that for crystal.
There's a piece there. Now these herniations come out in little pieces. So if you're a spine surgeon, I remember the first time I took a herniation out, I was so excited to be scrubbed in the surgery as a neurosurgery resident at University of Florida in Gainesville. And I was with my senior resident and he was going into the disc and he kept going in and coming out and going in and coming out. And he'd bring out little pieces of stuff. And I said, when are you going to get the herniation? And he said, I already did. I said, what do you mean? He said, all those little pieces I took out were the herniation. And I said, I thought the herniation was a big piece. And he said, no, no, no. Everyone thinks that. But in reality, herniation is many little pieces. So I thought that was an interesting learning point for me. All right. So here we are using the laser to blast away herniation at C6-7. Some scar tissue here you can see. All right, I need some help with this. If you can pull that to the side. Thanks, Luis. Luis is a lifesaver. So this is the herniation in the foramen right here. We're getting close. There's a piece of herniation coming out. Most of these in the cervical I float out. I think I float out most of the lumbar too. Just for reference, you see that little glass pipe at 12 o'clock? That is the laser fiber. And that laser fiber is 0.5 millimeter, 0.5 millimeter. Another piece of herniation. I'm going to have to grab that one because it's not coming out. It's too big. Get ready with the towel, with the Raytec. Okay. That should have done it. Let's hope. All right. So now I'm reaching over into the foramen on the patient's left foramen, C6-7. And you can see there's still a herniation here in the foramen. I'm zapping it down. And one of the things that are going to affect you if you do endoscopic surgery is the patient's chest. Okay? And what I mean by that is a big barrel chest has a high chest. It makes it harder to do the surgery because you're fighting the chest. Somebody with a narrow chest, much easier to do. But somebody with a big barrel chest, harder. There's herniation right there. Wow, that's a big one. Grab her. So that came out of the neuroforamen on the left, which is the side that we're most concerned with. There it is. Nice little chunk. Let's go back and take a look. How many fragments do we typically see in a herniation? It all depends. It all depends on how big the herniation is, what disc, cervical, lumbar, how many times there's been trauma. More traumatic incidents means more herniations. Every time you do trauma to your spine after you have a tear, you're going to get another piece or two of herniation. All right, you have any questions for me?
No questions.
I got to try to work on this. I'm going to switch sides. So the nice thing about cervical herniations is you can actually fix the whole herniation, both sides, with one entry point into the disc, like I'm doing with this one. Right? You don't have to go on both sides like you do in lumbar. For patients with a lumbar disc herniation, I go on the side they have leg symptoms like leg pain, numbness, tingling, weakness. But for cervical, you just choose a side to go on. And I always, in cervical, I go opposite of the worst arm symptoms. Okay, so if the patient has really bad right arm symptoms, then I go on the patient's left side of the neck. And if they have really bad left arm symptoms, I go on the right side of the neck. Now, there are some exceptions to that. If somebody has had, for example, a fusion or something else done already in their neck, then I would change sides and I would go on the opposite side of the fusion, because going through that fused area is too dangerous. There's too much scar tissue. You won't be able to separate the esophagus and the carotid sheath, or the trachea and the carotid sheath. And it's very important that you work between the trachea, esophagus, and the carotid sheath. Does that make sense? So you really do have to have what's called a plane of separation. And that plane of separation is very important. Gosh, look at all these pieces of herniation. So lasering them is going to be very inefficient to zap them away and debulk them. You'll be here for hours. That's not good for the patient. So it's better to go in and grab them out when you can. Some herniations are stuck to the annular tear, others are not. I don't know if I got anything, but it's a little hard to tell. Either way, we have to go back in. All right. So.
We have a question.
Sure.
Yeah. Can you fix damage caused by a fusion?
Can I fix damage caused by a fusion? Usually not, if it's damage caused like by the surgeon during the surgery, but it's a very important question and a very complex answer. There's a herniation right there. Okay, so virtually every patient that's had a fusion and has pain afterwards, I can fix. And the reason is because the surgeon did something wrong that's fixable, okay? Now, if the surgeon did something wrong that's not fixable, like paralyze you during surgery, I can't fix that. But if the surgeon just left a herniated disc or didn't treat all the herniated discs and left a couple in there, I can go in and fix those herniated discs that they didn't treat. And by the way, that's like 95% of the time. The surgeon leaves, a herniated disc either above the fusion or below the fusion. Then they call it adjacent segment disease, but what it really is I should have fixed that when I was there the first time, but I didn't, because I had a tea time at 3 o'clock and I didn't want to miss it with my buddies. And drinks are half price at the golf club. Okay, sorry, but that's the truth. It comes in many forms. You pick you choose your imaginary scenario, but point is the surgeon didn't fix all the discs that needed to be fixed. Now this guy right here we're fixing, he's got 4 damaged discs, but I think 3 of them are causing 99% of his symptoms. So we're fixing 3, not all 4. Okay? But that's because I have many years of experience doing this, and I'm really good now at figuring out which discs cause symptoms and which don't. Make sense? So if I wasn't 100% sure, I would do what's called a discogram to figure it out. So what I'm saying to you is that most spine surgeons, when they do fusions, they don't do all the fusion they're supposed to do. Okay, and they actually leave patients with herniations. And those herniations cause problems for the patients after surgery. So the patients are not happy with the results and they want to do something more. And I don't blame the patients. Okay? So yeah, we could probably help you, but I need more information. I'd need to see an MRI scan, at least, you know, or a CAT scan, so I could see what's actually going on. Another piece of herniated disc. I hope I answered that enough for you. Again, all these little things are herniated disc, and we're just removing it. There's a big one right there I'm going to have to get to. It looks pretty scarred up. You doing all right?
Yes, sir.
How's our irrigation? Did you order the...
We order, yeah. Make sure I don't touch me.
What is the issue?
No, I should just telling Jeremy to need to make sure that laser power don't touch my face or your face.
Yeah.
We have another question.
Sure.
On YouTube, they're asking, a patient has had 2 nerve blocks and the pain is not going away. In both arms, she's experiencing tingling and weakness. 3 disc herniations. Is this a good treatment and what is the risk?
Yeah, so you got tingling in your arms, you got arm symptoms, we call it radiculopathy, and you've got 3 herniated or bulging discs. Is this a good treatment? This is the best treatment for you. That comes from me, a surgeon who's done 1,000 fusions and artificial discs. This is by far the best treatment because we're not fusing you, we're not doing open surgery, we're not cutting your neck open like the other surgeons are going to do. We're doing it endoscopically. So I used to do lots of fusions and artificial discs years ago because they work well for that problem you're having. But they're very invasive. And, you know, people have trouble swallowing afterwards because of the scar tissue from the metal plate being put in. And there's a lot of complications that happen from those surgeries. So adjacent segment disease is just one of them. So once I started doing the laser surgeries 15 years ago, we never had any of those complications. As a matter of fact, I've been doing this surgery now 15 years with a 0 complication. 0. I don't like talking about it during surgery because I might jinx myself, but we've literally had no complications. We published 0 complications back in 2012, 2013, when we published in the National Library of Medicine and Surgical Neurology International. And we still, even to this day, have had 0 complications with these surgeries. Now, 1% of the patients are going to have a recurrent herniation. That means they're going to re-injure their neck and have another herniation where I did surgery. That's the only thing that's bad, is that you can get another herniation. But you can get another herniation with any surgery, even with a fusion. You can get a re-herniation or an adjacent segment herniation. So this is the best surgery in the world available by far. The surgery takes an hour to do, and you recover for 45 minutes and go home. There's no hospital stay. There's no risk of COVID or any of those other bad things. And by the next day, you're pretty much back to normal. You can drive, you can go to work if you want. Most people want to take time off for a week or 2 from work, but you could go back to work the same day. I mean, not the same day, the next day, if you want to. All right. So, thank you, Louise, for holding that aside. I've just got to finish cleaning this tear up here, and then we'll be done with your side of the disc. Just get all this stuff out. Great question. Everything okay?
Everything.
Great question. So why do people need herniated discs treated? You know, it's not your whole disc that's the problem. It's just the part in the back. The part that we're addressing right now, literally in the back of the disc. This is all that's wrong with your disc. The rest of the disc, yes, it may be degenerated, it may be damaged, but it doesn't cause any symptoms. It's literally just the part of the herniation in the back of the disc that causes all the problem. So why take the whole disc out just to fix the little part in the back? Okay? That's really the big question. And I wasn't the first person to do endoscopic anterior cervical transdiscal surgery, but what we figured out here at Deuk Spine was that it wasn't just the herniation that was the problem, it was the tear that the herniation came out of. And by repairing that tear, we could get rid of their neck pain, the patient's neck pain and headaches. So our goal has become not just to fix the arm symptoms, but also to fix the neck pain. So that's what makes us different, is that other endoscopic surgeons, and there's not many in the world, there's only literally probably 5 in the whole world that do cervical transdiscal surgery like this. Those 5 only care about arm symptoms. They don't care about neck pain because they can't fix your neck pain. They don't even try. You know what I'm saying? They won't even try. So they just deal with the arm symptoms. They won't try to fix your headache. They won't try to fix your neck pain. They'll just fix your arm symptoms with removing the herniation. And sometimes that doesn't even work. All right, we're at the back of the disc. I've gotten rid of most of the herniation. This is kind of bone spurish stuff, osteophytes. You've heard it called before. And you don't need to get rid of all the osteophytes. You just need to get rid of the ones that are causing problems. And knowing which ones cause problems, well, that's an art. So we are literally at the back of the disc. That's the end plate right there on the left of C6. That's the end plate of C7. And we're at the little crack at the back of the disc where the herniations are. And I'm literally zapping all that stuff away. Underneath this is the spinal cord. We don't want to be involved with that. We want to stay away from it. That's the uncinate process right there. That's the foramen. We've pretty much gotten everything out that was compressing and irritating.
We have a couple more questions.
Yeah. I'm going to sweep over to the other side just to look, because remember, this patient doesn't just have left arm symptoms, okay? He also has headaches and neck pain. So I got to make sure I fix the headaches and neck pain as well. To do that, I got to get the whole disc, not just one side. I got to get all the herniation and annular tear in the back. What's the question? We're just about done with this disc, then we're going to move on.
Yeah. Our viewer on YouTube says he has 5 ruptured discs in his neck and insurance refused to work on it. Why?
Well, all right, so 5 ruptured discs, insurance refuses to work on it.
Oh, excuse me. They refuse to work on all of them but one. Why is that?
Yeah. All right. All right, the surgeons are refusing to work on all of them but one. Because, number one, they don't understand that all 5 of them are probably causing pain. Because they don't understand where the pain comes from. You understand? That's really what it comes down to. And number 2, fixing 5 discs is hard. It's a lot of surgery. It's a lot of time. It's more risky for the surgeon. And surgeons don't want lawsuits. They just don't. So the more discs you're fixing in a surgery, the more chance of a lawsuit. So they just would rather avoid it and make you suffer in pain, and rather than expose themselves to a lawsuit, for example, okay? That's God's honest truth. So doing 5 disc surgery is very hard. It's very time consuming. It's physically and mentally demanding. And honestly, there aren't many surgeons that do it. So for somebody to say, hey, I'm going to fix all 5 discs in this patient because they need all 5 done, that's a big ask for a surgeon today. Now, I do it because I know that all 5 are needed, and I don't want the patient to have to come back for a second surgery. So I'll just do whatever's needed to be done during that surgery. Up to a limit of 5 discs, basically. But that's why you're having trouble. That's why they're not willing to do it. It's just a lot of surgery. And the second reason is they don't believe all 5 discs are causing your problem. But they're not trying to treat your neck pain. That's the problem. Surgeons don't do surgery for neck pain. They do surgery for arm pain, arm weakness, arm numbness, arm tingling, and spinal cord compression. So basically what they're saying is we think only one disc is causing all those symptoms.
Lights on, please.
Let me have the dilator. That's the dilator. You gotta learn this stuff.
Iodine, we have iodine. Please. Irrigation, please.
Do a little antiseptic. Let me have the dilator.
Wash your face. You have to, every time you...
You gotta step back, man. You have a needle? Let go of that, please. So, number one, surgeons don't believe in curing neck pain, but we do at Deuk Spine. But you're not going to find other surgeons that do. Number two, surgeons don't know what causes neck pain. They don't know how to cure it. They don't believe surgery cures neck pain. Okay? Most people don't believe surgery cures neck pain. But the reality is the surgery is the only thing that will cure your neck pain. But it has to be the right surgery. So if they only go fix one disc, that's not going to cure your neck pain. I need the needle on that irrigation. Yeah. So the medical community around the world believes that neck pain is not curable, that surgery is not the solution. There is no way to fix neck pain with surgery. I don't think that's the right one. It's the other one. Right? And so your surgeons aren't looking at your 5 herniated discs saying, oh, we could fix all 5 and cure your neck pain. They're looking at your problem and saying 5 discs, but only one of them is causing arm symptoms. We're going to go fix the one that causes arm symptoms. That's how they look at it. Okay. Huh? I don't know what you're saying. I need to do the usual anti-inflammatory. So at Deuk Spine, we look differently. We actually know we can cure your pain, but it's going to take surgery to do it, and we have to actually operate on all the discs that are causing your pain, whatever they are. If all 5 discs are causing your pain, we're going to need to fix all 5. If 4 discs are causing your pain, we would fix the 4 that are causing your pain. Okay? We don't do discs that don't cause pain. But I have to figure out ahead of time which discs are causing pain. Here, come on. I need you guys here with me right now. I need this not pointing at my elbow, okay? So whatever you do, get this out of the way. All right, we need the fluoro back in. So we have done the C6-7, back up please, disc repair, and now we have a C5-6 to do next. Our patient is still asleep. We've made 1 incision. It's 4 millimeters. We fixed C6-7, and now we're going to go in and fix the C5-6 disc. Shot. Is that it right there? All right, good. Actually, it's pretty good view of 6-7, right? All right. Now I need you to get 5-6 beautiful for me, okay? So now I have to track from C6-7 disc to C5-6, and I have to do that. That's pretty good with the dilator. Just play with the wag a little. It's got to be this towel. So the towel has a little bit of contrast in it, and that's what's making it weird looking. Shot. That should take that away and make the view better. Shot. All right, that's better. So you can see the dilator. I put it back at 6-7. I'm going to pull it out of the 6-7 disc. I'm going to march it along the front of the spine, along what's called the anterior longitudinal ligament. between the longus colli muscle bellies. I'm going to make sure I stay in the middle, and I'm going to make my way up to the next disc, which is 5-6. Are you ready? You can see we have a tiny incision, 4 millimeter. We had virtually no blood loss, and the whole surgery is done without cutting muscles or tissues, just the skin. Shot. Just about out. And give me inline traction, please. Keep the head straight, looking straight up. Don't rotate it, and keep it slightly extended. All right, so I am out. Shot. I can feel it. And now I got to march it. And I got to stay in the middle. All right, so I need to make sure I'm in the middle first. Give me an AP. Take your time. Give me a good AP. Coker. I don't want to radiate my fingers. And if you're wondering what the black gloves are, those are radiation gloves. They basically give me some protection of my hands against the effects of radiation. Please, please, please get the APs right. All right, it looks good. It looks good. Shot. Let's just get a little more centered shot. You can see the endotracheal tube and the esophageal tube deflected. I'm between them and the carotid sheath at the tip. All right, lateral. I need to make my way up one disc. So I'm very happy with where I'm at. Leave it. And I'm going to march my way right up to the next disc. I'm feeling the tip. Shot. A little bit of bone spur. Shot. I feel the bone spur. Shot. Shot. I need an AP. Coker. Give me a good AP. That's perfect. Back to a lateral. Nope, leave it there. All right, you inline traction? I just need you for another minute and we'll be good. All right, so I got to come back up. There we go, right there, shot. What?
No, you don't need to.
Shot. Who is that, Rita? Shot. That's perfect. Give me an AP quick. Nobody move. Hurry up. Perfect, lateral. So, I'm right at the front of the C5-6 disc. Nobody move. Give me a quick lateral. I need to get into the disc. Gently, carefully. Shot. Shot. Yes. Shot. Shot. Give me an AP. Just want to make sure we're making good progress and staying in the middle. Yeah, we are. Lateral. So this technique you're seeing is the one that I've developed here at Deuk Spine years and years ago, and you won't find it anywhere else in the world unless they're copying my technique, which is entirely possible. All right. Shot. So we're going to do a discogram now. And this procedure is called the Deuk laser disc repair, in case you're wondering. You can read about it. Shot. Now, we haven't gotten into this disc, right? This is the first time. Shot. Just need to clean out the pipe. We'll do our discogram. We're going to shoot the discogram right now. And I'm injecting really 3 things. A little bit of saline, a little omnipaque, and a little indigo carmine. Doesn't want to come out. Shot. Yeah. Shot. No, still clogged. Have that ready. Shot. Shot. Just a lot of arthritis in this space. Feel like a lot of scar tissue here. I can feel it at the back of the disc. Shot. Huh. Just doesn't want to come out. All right, let's do this. Give me a better view. I want to make sure we're lined up with the end plates. And I think you're off on the orbit a little bit. Shot. You can relax your hold on the head. All right, so try to make that better. It's pretty collapsed space. We are going to have to get to the back of the disc though to fix it. So I just want to make sure I'm seeing a good picture. Change the wag a little bit. Two, 3, 4, 5, 6. Yeah, 5, 6 is the most collapsed. I think that's probably as good as we're gonna get it. Let me have the mallet. Shot. Shot. That is seriously collapsed. Give me an AP.
Thank you.
Yeah, we're heading to the proper side. No, 5, 6. All right, let's go back to a lateral. He's still relaxed, right? How many twitches does he have?
Barely one. Not even.
All right, good. I don't want him fighting me with his neck musculature. Shot. Shot. All right, yeah, definitely collapsed at the back there. Shot. That's as good as we're gonna get it right there. Shot. So a lot of times I get to these really collapsed discs and we're just gonna do it without the injection. So these collapsed discs, if you remember what I said earlier, they're full of inflammation and scar tissue from chronic inflammation. Chronic inflammation means inflammation lasting more than 3 months. And for a lot of these people, it's years and years. No, stay there. We need the tube. For a lot of these patients, the inflammation's been going on inside the disc for years. So the disc is completely degenerated. It's collapsed down. It's lost the nuclear material, the jelly that was supporting it. And the disc is like almost bone on bone, but there's a lot of scar tissue between the end plates from all that inflammation. So what I do is I get in like I've just done. I get to the back of the disc with the tube, and then I start to release the scar tissue inside the disc. Shot. And amazing thing happens. The bones start moving again. Basically, the disc starts working again. So it's actually restoring movement. That's the one thing artificial disc can't do. Artificial disc can't take no movement and give it back to you. But this procedure can. And the reason is we're releasing the scar tissue inside the disc, breaking up the inflammatory tissue. Shot. So it's pretty remarkable what can actually be done endoscopically with the Deuk laser disc repair by doing the annular debridement. A lot of the scarring happens at the level of the annulus. You want to try to get that out? Without pulling the tube out. Let's see if you can move it. Again, we have some cold welding going on between the dilator and the tube. You get it?
Yeah.
Shot? Beautiful, nice job. All right, so there we are with our tube at the back of the disc. Kind of hard to tell because of the angle, because he has some scoliosis of his spine. But that said, I'm very happy with where we are, and our C3-4 needle is still in good position. So we're gonna get this C5-6 disc done, and then we'll head over to the C3-4 for our last disc for this surgery. Okay, this tube, I like the tube to be facing away, like this way. I think it's just we got too much tube, but that's fine. What other questions do you have for us?
Yes, we have a commenter on YouTube that says he had a fusion on C4-5 and 5-6 and is now having problems on C3-4 and C6-7. He wants to know if this surgery can be done for him.
Yeah, so great question. Person has had a fusion at 2 discs and now has adjacent segment disease above and below the fusion and wants to know if this surgery can be done. So the answer is generally yes. We can do the Deuk laser disc repair and repair the disc above or below fusion. However, to give you a 100% answer, I need to actually see your MRI myself. I need to look at it with my eyes. So we're inside the disc now. You can see some of the grunge in there. Inflammatory tissue, that's what we're looking at. When we send this stuff to the lab and then pathologist looks at it under the microscope, they always come back inflammatory changes, degenerative changes. So, but the answer is yes in general, but I need to see your specific films. And the reason is, what if your metal plate is riding over the disc that we need to fix and blocking access to them? Then we can't do it. And I need to see an x-ray to know that, or a CAT scan. What if there's a giant bone spur now, you know, sitting there blocking access to the disc above and below? That would be a problem as well. So I need to actually see your films. All right, we're getting ready to get started here at C5-6. This is all scar tissue from prior surgery and osteophytes. It is a bad shaped disc, but nonetheless, we should still be able to fix it, and I expect to eliminate his symptoms as a result. You can see a wad of scar tissue, like a little Grand Canyon of scar tissue right here between the vertebrae. All this stuff is calcified scar tissue and disc herniation. And we're going to start getting some chunks coming out. These won't be stained blue because they're so scarred up, and scar tissue doesn't stain blue with our dye. All right, look at all that scar tissue right there, all calcified. That's what the golden color is. The golden color means it's calcified. It's got calcium. That's what happens when the laser energy hits calcium. It turns golden. So calcium in tissues. We call this dystrophic, spelled D-Y-S-T-R-O-P-H-I-C, calcification. It means that your body's response to bad tissue, damaged tissue, is to calcify it and scar it for whatever reason. Nobody really knows why, but that's what happens, okay? I don't make the rules, I just follow them. Anyway, this is scar tissue. And now you're going to start seeing some movement as I start zapping some of the stuff away. At first, it's going to be really stiff. The bones aren't moving much, but by the time I'm done, he'll get movement back at this disc. Okay, watch that laser. Do not let you got to not let this hit my face.
Yes, sir.
You got put your hand there. Guard it. Get your hand up there. Yeah. All right, this is all scar tissue here, this canyon. And we're just herniated disc and scar tissue. We're just zapping it away. There is no tool in the world that can do this besides the laser. So when people make fun of laser spine surgery, they have no clue what they're talking about. That's kind of like, you know, people laughing about, you know, flying, you know, many years ago. Oh yeah, you can't fly. It's impossible. And then a jet flies over their head, and they're like, "What was that?" You know. When technology is so advanced that most people have no clue it even exists, and then they see it for the first time, and they're just they think the gods have descended from heaven. Well, that's what this technology is in the spine world. When you go and show a spine surgeon this surgery, they're like, they just can't believe what I'm doing. They've never seen anything like this done. Not even remotely. They're just, so how can you expect that doctor to recommend the best treatment in the world for you when they don't even know it exists, let alone know how to do it? Okay? So if you have a basilar apex aneurysm, an aneurysm in the brain that's going to kill you, and I'm a neurosurgeon, so I'm supposed to know how to fix that, which I do, but I was trained to do open surgery where you move the brain over and you gain access to the basilar apex, you expose the carotid or the vertebral arteries, or you have some mechanism of closing them off so they don't bleed to death if the aneurysm ruptures. The point is, very complex, very difficult surgery, requires special tools, special training. Even among neurosurgeons, it requires special training. I don't try to do those surgeries. Why? Because even though I did a couple of them as a resident, it wasn't my passion, and I never did a lot of them. And because of that, I'm not the best to do it, okay? But if I saw someone doing that surgery, I would say, wow, how is that even possible to go in and coil that thing? I've never seen that done before. Well, just because you've never seen it done before doesn't mean it's not the best treatment for a patient. What I'm getting at is just because your spine surgeon has never seen endoscopic surgery done before doesn't mean you shouldn't get it done yourself because your spine surgeon doesn't know how to do it. That's just silly. You as a patient, and that's why we broadcast these surgeries, you as a patient are kind of responsible nowadays for figuring out what's the best treatment for you and not just relying on what can my local surgeon do, So there's better treatments available now, but you're going to have to go out and educate yourself on what's available, and I know it's hard because, I'm also a patient, right? And when I need something done, I want to know, well, what's the best way to do it? So, unfortunately, there's no one book that everyone can go to read about the latest and best treatments available in the world for every medical condition. So maybe it's not a bad idea for someone to write that book. But, this surgery wasn't available more than 15 years ago. So it's something new in the last 15 years, but it's substantially better than anything else available. All right, so already starting to see a little more movement at the back of the disc here. Luis, are you able to get more of these tubes as well?
These one are hard to get it because.
I know, but you got to get them.
Yeah, I still search.
So either, no, not searching, you got to find them. Either you find them or have them made. Okay, you understand what I'm saying? There are companies that make stuff. And you have to talk to them and say, hey, can you make this tube identical? See if they can. And then, of course, talk to the company that originally manufactured it, see if they have any available. All right, so we're cleaning up the back of the disc where there's tons of scar tissue and herniated disc. And this, I can see from this disc, this has been going on for, I would say, at least 20 years. This is not a new injury to the disc. This is a very old injury. This is a very old injury to this disc. At least 20 years, maybe 30 or 40 years. So this disc is just, this is like really badly damaged. It's kind of like something rusting, a piece of metal rusting. And if the longer you let it rust without treating it, the more rusted it gets, the more damaged the metal gets. Now, none of these discs are beyond repair. Look at this. I'm actually zapping away the scar tissue and herniation back here. And it's working with the laser. Why? Because the laser is more powerful than any scar tissue, any bone spur, any osteophyte, anything in the human body. The laser is actually more powerful and can actually fix the problem. But unfortunately, most spine surgeons don't know how to use the laser, and they just laugh at it if you mention it to them because they don't understand what it can do. But we're finding more and more use for laser in medicine. Even in brain tumor surgery, there's now lasers that can be used to treat brain tumors. And this patient lives in San Francisco, and he went to UC San Francisco, and all they could offer him was a fusion surgery,
Occlusion.
which is what 99% of spine surgeons do, because they don't know how to do this type of surgery. This is a very state-of-the-art surgery, and he couldn't even get it done in UC San Francisco.
Thank you.
I will say that unfortunately in the United States there's a tremendous pressure for spine surgeons to do fusion surgery, okay, by companies that make billions of dollars a year selling those metal for the fusions and the cages, okay. They were pressuring me too when I was a resident. And then they're not mean about it. They don't say, I'll break your legs if you don't do fusions. They do it the opposite. They send pretty girls to the office, sorry guys, and they try to entice you and get you to use their products, their metal, and put their stuff in. And believe it or not, a lot of surgeons do it. They go for it, you know. I hate to say it, but I had a neurosurgery partner that was putting in all these different metal from these different companies because they would send lots of pretty girls to the office to take him out to lunch and dinner and on trips. So there's a lot of incentive by these companies to get surgeons to use their metal and put metals and screws and rods and cages in patients. It's big money. Now the surgery you're watching now, we're not putting any metal. So nobody's giving me anything for doing this except the patient and their insurance company. But that's why big places like UC San Francisco, they get a lot of support from the companies like Medtronic or Johnson & Johnson, and they make millions of dollars in additional money from those companies for research or education. It's all disguised, but it's really just a kickback. And so, of course, they're promoting the use of fusion and metal, okay? Big time. All right, just about done. I'm going to come over to this side one more time. And there's actually some good movement now. A few millimeters, not much, but a few millimeters. And a few millimeters is better than zero. I'm out the foramen here. Any other questions?
No, just a lot of praise saying that you're doing a great job and
Oh, good.
that
Thank
you're
you.
the best surgeon in the world.
Oh, I love that. Is that my daughter?
No.
Oh, too bad.
Thing is dilated.
My daughter's like, surgery, whatever. Where's my phone?
I will let you know.
Where's my, what do you call it? Those apps, What'd you say? No. The app on the phone the kids love these days. Snap,
TikTok?
Snapchat,
TikTok?
whatever. Yeah. She really doesn't even understand what I do, but I've tried teaching them so that they have an interest as well in helping people. And I think she's got a good heart, trust me, they do. I'm just kind of joking a little bit, but I have good kids. They're very empathetic. They're loving and caring people. So hopefully at least one of them will become a good surgeon someday and help people like I do.
Lights on, please. Come off. Dilator.
Yeah.
Iodine with the needle.
Formula One drivers are probably the most.
Along the lines of people who say that Formula One isn't a
Irrigation.
Yeah. Formula One is very athletic. All racing is athletic, not just Formula One. People don't understand how hard it is to race a car and take the car to the limit. Honestly, I didn't know either. I just thought you just hit the gas pedal and go. Yeah, the suit's not big. It's the G-forces that are crazy because they're literally pulling your body and pulling your organs apart in your body. When you hit like 4 or 5 Gs, no, they don't wear compression pants. They just wear a suit. Now, Arias got into an accident in his F4 car at Road America, and he hit the wall because the suspension failed on the car during one of the turns. Okay? And he hit the wall at 52 Gs. He hit with 52 G force. Yeah. Which is, he didn't black out. Nothing happened. He was like fine. He was just angry. Yeah, it was during qualifying, and he was not happy because he qualified like, I think, 5th. And he wanted to be on pole. So after hitting at 52 Gs, he got out of the car and he was just upset that he didn't qualify on pole. I'm like, are you freaking kidding me? I'm like, did your neck hurt? No. But that shows you how safe a lot of the most advanced cars are, that the carbon fiber and cockpits carbon fiber, the way they're designed. Yeah. Yeah. There's no water in the suit. No, they sweat. They get hot. Yeah, that's a cool suit. Those are, so there's two types of cars. There's those with a, interesting. The needle advanced a little bit at C3-4. But it's still safe. So there's cars that have an engine in the front, and there's cars that have an engine in the rear. And if your engine's in the front, then all the heat from the engine passes through the cockpit. So you need a cooling suit. But the cars that Arias races are open wheel with an engine in the rear, and so they don't get quite as hot as those guys and gals that do the racing with the engine in the front. All right, we are done with 2 discs, the C5-6, C6-7. You can actually see the 5-6 disc is a little wider now. We haven't added any nuclear material to it, but we've unstuck it so the end plates aren't stuck together as much. I'm holding a little bit of pressure. Basically, there's going to be some venous bleeding, and venous bleeding is at about 10 millimeters of mercury pressure, which is not that much. So you just have to hold it for a minute, and then any kind of veins that are torn, that are bleeding, will stop bleeding. We've lost probably 1 milliliter of blood, about 20 drops of blood so far. We're not going to lose much more than that for this surgery. It's pretty much a bloodless surgery. And for those of you wondering, how did I get down to the spine, is a technique that I learned overseas where you literally, and I can't take credit for this part, you put your fingers here between the, what's the sternocleidomastoid and the carotid artery on the outside, and then the trachea and esophagus medially, and you literally push the trachea and esophagus over, and you can feel the spine when the patient is asleep and relaxed. Now, if you're wanting to do these surgeries, obviously don't start doing them. You need to train, and you need to be taught how to do them like I do. However, I can tell you there's 2 schools. There are the Koreans who do it with the patient awake, and there's no neuromuscular blockade. They're not intubated. Their airway is not secure. They're awake. And then you have the Dr. Deukmedjian way of doing it, where the patients are intubated, put under general anesthesia, and most importantly, you know, for a lot of reasons. One, you secure their airway with a tube. You're ventilating them. The anesthesiologist can monitor all that, make sure they're oxygenating well. But also, because their neck is completely relaxed, there's no like tightening of these muscles. If I took my finger and stuck it on your neck right now and you're awake, your muscles will all tighten up and push my fingers away, and you'll gag. But when the patient's asleep, I can push everything over and not get that reflex contraction of the skeletal muscle in the neck. So that's really the main reason I do it this way, is I can feel the spine better. All right, we are ready to proceed at C3-4, which is the next level shot. Let's make sure our guide wire is in proper position, which it is. Take that scalpel away for a moment, please. All right, now I'm going to leave the guide wire and pull the needle back. Shot. There's a guide wire. You can see it. And things are a little sticky here, so I don't want to accidentally pull my guide wire out. It must stay in position. If we lose the guide wire, we have to start over. All right, now we got our guide wire in position. By the way, look at the other incision. For those of you wondering, can you see this, Diego?
Yes, they're seeing
4
it.
millimeter incision, okay? And just to give you an idea, what would this look like if we did a cervical fusion? It would be an incision about that long. Can you see that? As long as that, where my thumb is, up to the top. Okay? You imagine all the scar tissue and damage that would cause. So we're doing all this with 2 little pokes. It's going to look like a vampire with a bad dentist bit this patient's neck. But that's it. And those little holes are going to heal themselves, repair themselves, usually within a few days. And the skin is healed in 3 days and patient is back to normal. Can't get that with a fusion. Shot. Looking good. So we're coming down the guide wire with the dilator. And I'm going to dilate down. Shot. I want to keep checking my guide wire to make sure it doesn't go in any further into the spinal cord or that it doesn't come out into the neck. Shot. I want to just keep a close eye on it as I gently and carefully advance the dilator down the guide wire to the front of the disc. Okay? Remember, I'm on the side shot of the trachea and esophagus. I'm literally at the tip of the dilator, and the last picture is on the side of the esophagus. And now I'm behind the esophagus. I'm on the anterior longitudinal ligament, the ALL, right in front of the disc at C3-4. It's perfect. And we'll just verify with an AP view to make sure we're in the midline, that nothing is out of place. But look how beautiful this surgery is. We'll be done in 15, 20 minutes max. What was that? That hit the bottom of the table? Not the top, right? That was the bottom? Shot. It's too far over to your side. It's too far to you. It's too far to you again. All right, it looks perfect in terms of positioning. Very happy. All right, lateral. So folks, if you have herniated discs in your neck, if you have bulging disc, if you have degenerated disc, and you're in pain, you have neck pain or headaches or even arm symptoms, we could fix you with this laser surgery. You don't have to go through open surgery and you don't have to suffer in pain anymore. I'm online all the time. I'm reading Facebook posts by people that have horrible pain in their neck, herniated disc, bulging disc. They don't know what to do. They're told by their doctor, just take pain meds or take gabapentin or Neurontin, take some pill. Those pills aren't ever going to fix your problem. You need to have the surgery on the back of the disc done with the laser, the Deuk laser disc repair done. If you do it, your pain will go away, okay? As long as it's done on the right discs. If you're not having it done at Deuk Spine Institute, don't expect a good result. I can't vouch for other spine surgeons. I think most of them are just horrible. They're technically not good at what they do, and intellectually they can't figure out where the problem is most of the time. So I don't have a lot of confidence in my peers. I am a neurosurgeon, yes, but I'm not like other neurosurgeons. I wasn't trained exactly like them. So my philosophies and my abilities are different. And my focus is fixing pain, not just unpinching nerves. Okay. Yeah, we believe here at Deuk Spine that neck and back pain are important to fix. We don't let people just suffer. We don't send you to pain management. We actually fix it here ourselves because we have the ability to fix it with surgery. Pain management doctors can't do surgery. By the way, I'm seeing a lot of pain management doctors now starting to do surgery on the spine. It's crazy. So pain management doctors make $100 for an epidural. They make $500 maybe for a rhizotomy, the pain management procedures they normally do. But what I'm seeing is if they do spine surgery, they get thousands of dollars. So a lot of pain management doctors have started to do spine surgery. They've started to do the surgeries that surgeons are supposed to do. Why? Because the medical boards are not stopping them, and because they're honestly pigs, all right, for lack of a better word, a pig. because all they care about is making money, and they're putting the patient's safety at risk. If you're having a pain management doctor do surgery on you, you are basically taking a massive risk. You see, the problem is real surgeons, spine surgeons like ortho and neurospine surgeons, they don't know how to fix pain in the back or neck, so they're sending all their patients to the pain management docs. The pain management docs they have this population of people with pain in their neck and back, and they're like, oh, we can do whatever we want on you. So they're doing all these expensive procedures so they can make money, but they're not qualified to do. They've never been trained properly to do it. So this is a bigger and bigger problem that I'm seeing more and more. Pain management doctors doing surgery. If your pain management doctor wants to cut on you and do a surgery, run. Because they don't care if you die or are paralyzed. They hide from the bad outcome. But you got to watch out. That is not the standard of care. You should not have surgery done on your spine by a pain management doctor. Okay?
We have a question from Facebook.
Yeah. Okay. Yeah.
Okay.
Shot?
We have a patient that is from West Virginia, says hello, and he says, can this surgery be done on a vertebrae that has been crushed in the thoracic area?
Great question. So this patient in West Virginia, hello. By the way, I was just in Virginia. Today is Tuesday. I was there this weekend. Friday, Saturday, Sunday. Can we not hit the table with the floral? I was at the Virginia International Raceway for 3 days. Beautiful, absolutely beautiful place. And the leaves are starting to turn, just gorgeous, great weather. Anyway, long story short, can this laser surgery be done to fix a fracture in the thoracic? The answer is no. The Deuk laser disc repair is designed to fix herniated or bulging discs that cause pain, not fractures. So a thoracic fracture can be fixed easily with a procedure called a kyphoplasty. Kyphoplasty. So if you have a fracture in the thoracic spine, and it is a what's called an insufficiency fracture of the vertebral body, as long as it's a vertebral body fracture, you can get a kyphoplasty done. That is a very straightforward procedure. There's lots of surgeons that do it all over the country. It's a needle that goes into the bone and fills it with cement to stabilize the fracture. Now, if you have a different kind of fracture, like you have a motor vehicle accident fracture, you may have a fracture dislocation, and that's a different beast altogether. So I need to know what kind of fracture you have, but if it's a simple compression fracture, insufficiency fracture from being osteoporotic, then a kyphoplasty is the best treatment. As long as there's no disruption of the posterior cortex in the back of the vertebral body, as long as you don't have a crack back there, all right? So vertebral body compression fracture, kyphoplasty, best treatment. If you have herniated discs above or below the fracture and they're causing you pain, then I would say you want to do the laser surgery you're seeing here. So it really depends on what's causing your symptoms. Is it the fracture, or is it the herniated disc above or below the fracture, which frequently happen as a result of trauma? So I don't know. Now, there is another cause of vertebral body fractures. It's called pathological fracture. What that means is there's an infection or a tumor that's living in the bone, growing in there, eating it away, and basically destroying the bone, making it weak, and then you fracture. So do you have a pathological fracture? That you need an MRI scan with and without contrast to make that determination. So if the contrasted MRI shows a tumor in the bone, then you got to deal with the tumor. So it's a little more complicated than just answering yes or no on the video. You need to get to the source of the fracture, and we need to know what kind of fracture it was. Is it a traumatic fracture? Is it a pathological fracture? Is it an insufficiency fracture? Is it of the vertebral body? Or is there a fracture dislocation that involves ligaments as well and joints? So those are the important things we've got to figure out. What's your alignment like? Is there neural compression? Is your nerves being pinched? But the laser surgery you're seeing now is not the right treatment for any of those. On the other hand, if your fractures heal and you still have pain and you have a herniated disc above or below the fracture, that's probably the cause of your pain. In that case, this surgery would be perfect for it. So if you want my opinion, just fill out the free MRI review and I can do that for you, but I've got to see your films. Just use one at a time, okay, not two. And use the middle surface of it so you capture the disc and you can clean it off and send it later for the pathology. Okay? Be smart about what you do, how you work.
She says thank you.
You're welcome. All right, so this is actually a very different looking disc than the last one. Look at all this stuff. This is all herniation, by the way, but it's far less scarred than the other one. So this injury is, believe it or not, his disc is more recent. Now there's still calcium deposits in the herniation and the annular tear. So it's not like, it didn't just happen yesterday. It's probably happened a few years ago, but it's not like that other one that's probably 25, 30 years old. That C5-6 one. But this has got a lot more of the disc material. So I'm making my way out to the foramen once again, floating out these fragments of herniation. I'm heading off to the left foramen at C3-4. Why? Because he's got left arm symptoms. So I want to make sure I get that foramen decompressed, and I want to clean out any herniation in the foramen, and I want to clean out the annular tear in the foramen. Look at that herniation right there. Trying to get out. I'm trying to release it so it can come out. There. Pretty cool. All these little chunks of herniation coming out. And I'm floating them out. And the reason I can float them out is I'm using a saline irrigation going down this tube through an IV. There's a bone spur. And I'm gonna have to grab that out. It's too dense. So if you enjoy Deuk Spine Institute's educational videos, we have a lot of videos on YouTube. We have probably over 1,000. And we have lots of testimonials of patients who have had the laser surgery over the last 15 years. We also have some educational videos that show how herniated discs cause pain and how the Deuk laser disc repair works. We also have reaction videos where I'm talking about important topics in spine, like insurance or artificial discs, or lots of things. Kickbacks to surgeons from implant companies. I mean, you name it, we cover different topics every week. And Diego has been very instrumental. Diego is part of my broadcasting team. He's been very instrumental in working with me to get these reaction videos out onto YouTube, along with John May. And hopefully you find them not just educational, but also entertaining. Woo, lots of herniations here. And these are more collagenized. More collagen. They have more collagen. The white stuff. So I'm breaking them up with the laser and floating them out with the irrigation. Irrigation is just usually saline fluid that goes into the surgical wound during surgery. The thing about endoscopic surgery is you always need irrigation. Whether you're doing a knee or a shoulder endoscopic surgery, you use irrigation. Please don't try this surgery at home or in your garage. This is, we make it look easy, but it's really very advanced technique that 99% of spine surgeons can't do because they don't know how to do it and they don't have the right equipment or training to do it. So please don't try this on your sister made dog walker. Get it done right. Get it done right the first time. You won't have to do it again. All right, so that left foramen is pretty collapsed and arthritic, but I don't see any more herniation in there. One thing about the laser that I use, that if you're going to do this surgery, you must use this laser, Homium YAG. There's nothing I do that's happenstance or chance. This laser is special. It actually does more than annihilate the bad tissue and destroy it by vaporization. It actually does something else very important. Anybody know what that is? Luis knows. Let's see if our audience knows the answer. Besides vaporization, what else does this laser do? Let's give our audience a few minutes and I will tell you. But you can actually see it right now if you're paying attention. I've mentioned it before. The engineer will appreciate it. We're going to be done in 5 minutes. Doctor, if you want to start getting him ready to wake up. And we have one more surgery to do. But anyway, as I was saying earlier, if you enjoy our educational pieces at the Deuk Spine Institute, then you may want to download our app. Go to your phone and go to the App Store and look for Deuk Spine Institute app. The only problem is it costs a lot of money. Just kidding, it's free. And it's got lots of great content that will bring you up to speed on the most modern advanced diagnostic and treatment options for patients, along with the most common spine diagnoses. I was saying earlier, at Deuk Spine we treat what are called degenerative conditions, which are the most common problems people get in the spine. All right, there's also cancer of the spine, there's infections of the spine, there's trauma like fractures, acute fractures of the spine, but the most common spine disorders are degenerative. And degenerative spine disorders are what we specialize in. And that's 95% of spine issues today around the world, even in cities that have car accidents, a lot of them. The most common reason to have a spine issue is a degenerative disc, a disc herniation or a pinched nerve. Okay? So that's what we treat. And we treat them with this laser endoscopic surgery, what we've been doing now 15 years. We've had 0 complications to date. Pretty cool, huh? Those look like fibers of the posterior ligament right there. You see them? They're kind of bluish, but they're running up and down. This is the foramen. And this C3-4 had a bigger herniation on this side than it did on the other. So I'm making sure we're getting it. Did somebody come up with the answer of what the laser does besides vaporize?
No, we haven't.
Oh my gosh. I have to cavitation. That's correct. It creates a pressure wave. And that pressure wave in the liquid blasts like a pressure washer. It blasts everything out of little holes. Cavitation. Cavitation is a powerful sound wave moving through liquid. It causes the liquid to deform or cavitate. Do I have to teach you all everything now? Huh? Just kidding. Don't mind it. Just about done. Breaking up this herniation into little pieces and getting rid of it. All right. Huh? Be done in 3 minutes. Any more questions from our audience?
The same lady from West Virginia says, "Thank you, and I'm getting ready for another MRI, and then I will submit it to you."
Yeah, send us your MRI. We will look at it for you and tell you what's wrong.
She also adds that she told them about the surgery that you do, and her representatives say that she was told that she wasn't a good candidate for the surgery.
She told somebody about our surgery and was told by her representative?
Somebody that she wasn't a good candidate.
Somebody here at Deuk Spine?
No, somebody at her MRI place.
Listen, I'm going to tell you something that maybe we haven't really talked about, but we should talk about. Folks, when you go to your neurosurgeon, spine surgeon, or orthopedic surgeon, and you mention this surgery, laser spine surgery, they're going to say to you, many of them are going to say, oh yeah, that's really good surgery, but you're not a good candidate. How many times have I heard this? Those surgeons don't even do laser spine surgery. Though what they're trying to do is basically get you to go to them. They're telling you what you want to hear, which is, yeah, it's a good surgery, but you know, you're not a good candidate because you have something that's not good. The reality is they have no clue what they're talking about. Of course you're a good candidate. They just don't want to lose the business, okay? Listen, that's irresponsible of that doctor. If they say that to you, they're lying to you. Don't believe them. Don't listen to them. They don't have your best interests at heart. When I have patients that I see that have problems like brain tumors or aneurysms, I don't try to fix them. I can make lots of money fixing them, but I don't, because I know that patient's going to get better care somewhere else where there's a good expert that does a lot of those surgeries. I'm not that person. So I'm giving up money and business to send my patient to the best place for their medical problem. Well, unfortunately, yeah, lots of spine surgeons, they don't want to lose the money from the surgery. So they're going to tell you lies, tell you that you're not a good candidate for this surgery, even though they have no clue what they're talking about. That's why we broadcast, folks, because there's so much what I call misinformation. And I don't like to say lies, because sometimes it's lies, but many times it's not lies. Many times it's just stupid people who don't really understand what's really going on in the spine. And that's about 90% of the time. 10% of the time there are charlatans out there that will lie to you and tell you that this surgery doesn't work, even though they themselves have no clue if it's going to work or not. They just know they can't do it. So they don't want to lose the business. To me, that's unethical. If there's a better treatment somewhere else, you should tell your patient about that better treatment. That's part of what's called informed consent. Informed consent. So when a doctor doesn't tell you about other treatments that are available, then basically they're not practicing informed consent. Okay, and that's a violation of not just medical ethics, but also it's illegal. It's illegal for a doctor to do treatment without giving you information about alternative treatments, okay? So we talk about all treatments here, whether it's fusion or artificial disc, laser, medications, injections. We do them all here, by the way. So not only do we talk about them, but we offer them. It's just that the best treatment for herniated disc, degenerated disc, is the laser surgery, hands down. And that comes from someone who does all treatments, including injections, medications, therapy, chiropractic, everything. Okay? All right, I'm going to show you, we had to do 2 incisions. Each one is just 4 millimeters. And we were able to repair those discs. The discs were damaged with herniation, annular tear, and degeneration. And they were not the same. The one at C5-6 was by far the worst and most degenerated. C3-4 was the least damaged. C6-7 was the second least. C5-6 was the most damaged. So it doesn't matter if it's a herniation or a bulge. It doesn't matter if it's degenerated, stenosis, spondylosis. We can fix it with this laser surgery. I think he's going to be very happy with the results. I think his headaches will be gone, his arm symptoms will be gone, and his neck pain will be gone. Now, he may have a little bit of pain today, but by tomorrow when he comes to clinic, I think all those symptoms will be gone. There's your incisions right there. You can see them, folks. It looks like literally a vampire bit him, right? Those are vampires. So he can tell people he went to Florida, and when he met Mickey, Mickey bit him in the neck and sucked his blood. All right, if you can't have fun with surgery, then what else are you going to do? We like to have fun. All right, type up your questions, and I'll be happy to answer them for you in a couple of minutes. In the meantime, why don't you run a comparison video, ACDF versus Deuk laser disc repair, so everyone can see the difference.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.